My name is Allison McCain. I'm Deputy Director with the Kansas Council on Developmental Disabilities. Thank you for joining us for this important conversation. This presentation is brought to you by the Kansas Council on Developmental Disabilities and really originated out of conversations with families who have utilized hospice care for their loved ones with IDD. So we're glad you're here with us today. Before we get started, I'd like to go over a few quick housekeeping items to help things run smoothly. All participants are currently muted to minimize background noise. We ask that you please remain muted during the presentation unless you're called on to speak. If you're experiencing any audio issues, try leaving and rejoining the session or using that dial-in number that should have been in your confirmation email. We will have time for Q&A at the end. I know many of you submitted questions prior to the webinar. We tried to answer those in the presentation, but we will have about 10-15 minutes to answer any questions that you have. During that time, please use the Q&A chat box down at the bottom, which you can find it on that lower level. And then we are recording this webinar, so it will be posted on our website after if you have to jump or want to come back to anything. We also have closed captioning available. You'll see that down at the bottom, that CC button, and you can turn that on if you'd like. And I am going to go ahead and start the webinar by asking our fantastic speakers to introduce themselves, and then we'll dive right in. Thank you both for being here.
Thanks so much, Allison. My name is Taylor Jersak. I am one of the doctors on the pediatric palliative care team at Children's Mercy in Kansas City. I also practice adult palliative care at the University of Kansas in Kansas City and have an adolescent and young adult palliative care clinic housed at KU.
And my name is Dr. Jane Chargot. I am a doctor practicing palliative care, mainly in adult medicine. I do inpatient consultations at the University of Michigan. I also am the lead physician for the University of Michigan's outpatient palliative care clinics. And so I practice within the outpatient world as well. And I also do a little bit of family medicine too. So I'm a primary care doctor too. Before we get started, I just wanted to take a moment from the both of us to thank all of you for being here today. It's truly amazing from really all of our perspectives to see so many people here from so many different places who have interest in not only learning about palliative care, but also caring for the IDD population more fully throughout their lives. So we have no disclosures today. Our objectives are to review palliative care and hospice, to understand the barriers to palliative care for individuals with IDD, special considerations for palliative care for those patients who are in the IDD population, advanced care planning, what is it, and how to approach ACP in the IDD population, and palliative care in special populations, specifically adolescents and children. So this is one of my favorite quotes from Dame Cicely Saunders, the founding mother of hospice care. You matter because you are you, and you matter to the end of your life. We will all do what we can, not only to help you die peacefully, but to also live until you die. So what is palliative care? It's specialized medical care for people living with serious illness. It's focused on symptom management and the stressors of living with serious illness with the goal of improving quality of life for the patient and their caregivers and loved ones. Care is provided by an interdisciplinary team. So that means doctors, APPs, or people like nurse practitioners or PAs, nurses, social workers, pharmacists, chaplains, and many more. It's appropriate to consider palliative care at any age and at any stage of a serious illness. And it is provided alongside medical care focused on curative intent or life extension. Most people are really uncertain of the difference between hospice and palliative care and typically align them as being the same thing. But palliative care really is an umbrella continuum. We can provide care from the time of diagnosis of a serious illness all the way through to their end of life. And this graphic really helps demonstrate palliative care's involvement in an illness trajectory. While referrals can happen anywhere from the time of diagnosis to the end of life, we often encourage early referral to help establish understanding of the patient, their needs, and to establish a trusting relationship. We are then more able to intervene at times of need, such as when disease progresses, there are worsening symptoms, or in anticipation of decision points. And as you can see in this big blue square, palliative care happens at the same time, here's palliative care, as treatment focused on the disease itself. So maybe focused on extending the patient's life, maybe focused on potential curative benefits. So things like cancer, or heart failure, or other potentially life-limiting disease. These two focuses can happen at the same time. As people transition to the end stages of their disease and have a prognosis of 6 months or less, we begin to consider a transition to hospice care. So then what is hospice? It is when a person not only has an expected prognosis of 6 months or less, but has also either opted out of or has no further options for life-extending treatment. It is when a person has decided to focus their medical treatment on the goal of quality of life rather than extension of life. Hospice can be at home or in a facility. Hospice in a home is essentially free of charge, and it's provided by most insurances, including Medicare and Medicaid. Its focus is on quality of life and symptom management at the end of life. The team is a multidisciplinary team. It usually consists of a physician, possibly an APP, nurses, home health aides, social workers, and chaplains. And many have other external support services such as music therapy, massage therapy, art therapy, animal therapy, and volunteers that offer respite hours for the loved ones. Hospice also can provide home delivery of medications, durable medical equipment, and they are there for on-call services 24/7 for urgent needs. And then they continue to provide bereavement care for the patient's loved ones for up to 13 months after their passing. Some things that are often misunderstood about hospice at home is that while hospice does provide a significant amount of care support in the home, the patient's loved ones remain their primary caregivers. Nurses typically come out about 1 to 2 times a week and are on call if symptoms change and need urgent addressing. Home health aides come out 2 to 3 times a week for a few hours to help with cares, and social workers come out at least once and then are available as needed, and chaplains are also available as needed as well. But none of this, we do not provide 24-hour care in the home, unfortunately. Hospice within a group home or an adult foster home is very similar. The caregivers within the home remain the primary caregivers with an extra layer of hospice team support. Importantly, when patients live in group care homes, making sure that there is a consistent contact person who would take point to facilitate communication between the caregivers and the hospice team is crucial. And additionally, making sure that the legal decision maker is always available to the hospice team and the caregivers. The hospice team can also care for patients who are living in a facility such as a nursing home facility or other long-term care facilities. When this occurs, the patient's caregiving team is the facility staff with the oversight and support by the hospice team. The hospice team will send nurses, home health aides, social workers, chaplains, much the same as they would if they were receiving hospice at home. It will cover medications, necessary medical equipment outside of that is provided by the facility, and bereavement care. Some hospices also run their own hospice house. This is often limited to a dozen or so beds that are directly run by a hospice healthcare provider, and they provide 24/7 hospice care to the patient that is residing in those hospice houses. The decision to transition from home to a facility for hospice care can often be really difficult on family members and their loved ones. But often it's really necessary when the complexity of care increases beyond what a family might be able to provide at home. And we often discuss that this transition allows the patient's loved ones to be their parents, their siblings, their loved ones, rather than their primary caregiver, and eases that burden and worry. The greatest barrier to hospice in a facility is the cost. Daily fees are often $300 to $700 a night. Medicaid does pay for room and board for their patients depending on the state, but the facility has to have a qualifying bed available. And Medicare, unfortunately, does not cover room and board costs. So what are some of the barriers to palliative care? We'll briefly touch on these and then delve into them a bit deeper in the next slides. Access to care, provider education regarding palliative care as a resource to patients with disabilities, and communication barriers between healthcare providers, loved ones, caregivers, and patients. So just getting into medical care is the first overwhelming barrier for patients living with disabilities. Finding a primary care provider that is comfortable caring for patients with disabilities is often a significant challenge. And then once you're over the hurdle of attaining a primary care provider, depending on the locale, many patients might really struggle with getting access to specialty care, including palliative care. They may be dependent on others for transportation and arranging their appointments. And there's often significant communication barriers, which we'll delve into deeper in the next few slides. Patients living with IDD and other disabilities are often very isolated. And their caregivers are often their parents or family members. And as they age, there might be more limitations to their medical care access and further isolation. Here we go. Okay. Patients are living longer and longer with disabilities. They have near parity lifespan expectancy to those who are not living with disabilities. Their leading causes of death are now more typical: heart disease, cancer, lung disease. And despite primary care and specialists' expertise and experience in caring for patients with these chronic diseases, patients with IDD and disabilities continue to not be considered for palliative care in comparison to the general population. Under-referral is across the board for patients with and without IDD, but particularly poor in those patients with disabilities. A lot of our data comes from countries with universal health care, places like Canada, the UK, the Netherlands. UK's NHS data shows that only 18% of patients with IDD are referred to palliative care, even within their end of life. And very similar findings are from the Netherlands, and those show also that few resources for those living with disabilities cite palliative care. And primary care providers surveyed within that study also noted that they typically did not consider palliative care as a resource for their disabled patients. This is in contrast to our US Medicare data showing that approximately 30 to 50% of Medicare recipients without IDD utilize hospice at their end of life. So what is this telling us? Number one, that providers and the general population are not well educated about palliative care and hospice. Number two, that there are barriers to referral even when resources are available. And number three, palliative care continues to be a limited resource across the board. So what are some communication barriers that are factors within the caregiver and the healthcare providers? Healthcare providers often assume that patients with disabilities and IDD do not have autonomy over their own care. However, we know that patients who may not have capacity to independently make complex medical decisions can very often make their preferences known and should have those preferences heard and considered during decision-making processes. Healthcare providers, caregivers, and family members all may assume that a patient with IDD would not understand concepts like sickness, death, dying, and health, truly, or recognize any of these changes within their bodies. They often feel that if these concerns were brought up to the patient, that it would cause them a great deal of distress or scare them. And because of unintentional failure to engage with a patient on this level, the healthcare providers and their caregivers may overlook signs of illness or distress, and thus it might lead to a more advanced illness presentation. And so I'd like to talk a little bit more about patient factors that are barriers to communication. Patients may have unconventional ways of expressing their distress. Healthcare providers need to be open to behavior change and other signs of distress as a way of communication by the patient. Expressions of distress can run the gamut: withdrawal, behavioral change, crying, self-harm, things like hitting, biting, pulling their hair, loss of interest in their favorite things. It can be really difficult to elucidate the cause of this distress, depending on the severity of their IDD. And it might be difficult to understand, are these symptoms and expressions representing pain? Are they feeling sick? Are they fearful or anxious or worried? Are they sad? Patients live in their bodies. When things are changing, if this is not acknowledged and discussed with the patient at their level of understanding, it can be incredibly frightening. Some patients may interpret illness and discomfort as a punishment, or maybe even being their fault. So don't be afraid to ask these questions of these patients. Don't be afraid to bring these up in ways that they might be able to better understand, and then provide reassurance and revisit these themes as often as is needed. In the case of mild to moderate IDD, patients are often scared to ask questions, and frankly, so are patients who have quote unquote normal cognitive function. It takes time and it takes space in the clinical setting for them to ask their questions. And if they're dismissed or not even given the opportunity, they might be more reluctant to do so in the future. They often may not even be acknowledged in the clinical setting if they're accompanied by a caregiver, and that might make it even more challenging to express their questions or their worries about their own health. They might have alternative ways of communicating. They may use devices such as tablets. They may need an interpreter. They may have a tracheostomy. Their healthcare providers need to have adaptability to adjust to those needs. And time. As a primary care doctor, as a doctor in general, time is a huge factor. We need to have enough time available in these appointments. We may need to have extended visits, or we may need to have flexibility on where the patient is being seen. To do this well, the healthcare provider needs to gain a level of understanding about the patient and also about the communication needs of the patient and meet them there. What is a normal day like for a patient? What sorts of activities do they enjoy? What things might make them upset? Would coming into a clinic be really overwhelming and frightening for them, and thus limit the patient's ability to easily engage with the provider? Maybe meeting them at home, and if this is unavailable to the physician or the provider, simply going out and meeting them in the parking lot and sitting with them in their car might be preferable to the exam room. Signs of distress may also be in response to the reactions of those that they love who might be sad or upset in the setting of the patient's illness. So being careful not to ignore that. And also being careful to avoid language that undervalues their life. And I'm particularly thinking of words like futility and similar. So how can palliative care help? It can help enhance medical communication with patients, families, and caregivers. It can help with advanced care planning, improved recognition and care of spiritual and psychologic needs. It can assist with recognition and understanding of disease progression and health status. It can aid in complex symptom management, resource coordination, and more. So what is advanced care planning? Advanced care planning is the process in which a patient, their loved ones, and their medical team discuss and document a person's medical goals, values, and preferences for future medical treatment, particularly as their disease advances. This can involve making decisions regarding code status, escalation of medical care, and treatment options. Typically, these discussions fall to the primary care providers, who might, not always, lack experience in walking patients through these considerations, and very often are limited by time. Referral to specialty palliative care earlier in the disease process can really help overcome some of these barriers. Early referral allows for providers to establish a rapport and trusting relationship, overcome patient barriers to understanding and communication. And again, even if the patient does not have decisional capacity, they can still voice their preferences, and their autonomy should be part of the decision making and respected by the medical team.
So because these advanced care planning conversations are complex and layered, it can help to provide a written framework to guide the conversation. So these are several examples of advanced care planning tools. They were created by the nonprofit organization called Aging with Dignity. And these forms are available either by print, and there's also fillable PDF forms online as well. 5 Wishes is made for adults 18 years and older, and it goes through choosing things like a power of attorney for healthcare, specifying the type of care a patient may wish to receive if they were to become seriously ill, and clarifying any limitations for medical technology or other interventions. My Wishes was designed for children younger than 18 years, though it can also be helpful for people who may express themselves through drawing or have limited verbal skills. It provides blank pages with some open-ended prompts, such as, "These things make me feel safe," and then gives space for either drawing pictures or writing freehand. Voicing My Choices was designed for adolescents and young adults living with a serious illness and uses more developmentally appropriate language for this age group. It begins with lighter topics such as how I want to be comforted, my favorite music is, and then as they progress through the guide, it begins to address more serious topics, even covering things such as preferences about life support. And at the end, it gives space to express thoughts on legacy making, spiritual care, and funeral planning. I love that these guides give people of all abilities a way to express preferences on their care in the setting of serious illness, whether it is expressed verbally, written, or through pictures. Next slide, please. So for a person with a serious illness and a risk of acute deterioration outside the hospital, some patients or decision makers may feel that aggressive medical interventions or resuscitation efforts could actually lead to more harm than benefit. And in these cases, we may bring up a community or an out-of-hospital DNR or do not resuscitate form. So these are 2 examples of out-of-hospital or community DNR forms for the state of Missouri and Kansas. The form is signed by a physician and the patient, parent, or guardian. It is a tool that families can have in their home that allows them to determine if they would want resuscitation to be attempted outside of the hospital in an acute deterioration. In pediatrics, if a family member calls 911 and the child does not have an out-of-hospital DNR form, the emergency response team is legally obligated to begin resuscitation, regardless of what conversations have been had with family members or care providers in the past. If they have an out-of-hospital DNR form, it then gives the parents or caregiver or other legal decision maker the ability to choose allowing a natural death. Some families may choose to present this form if their child had a sudden end of life overnight that was related to progression of their underlying diagnosis. But the same family may choose not to present this form if their child developed sudden respiratory distress from a potentially reversible cause like pneumonia. So we let families know that by having the form in their possession, it does not necessitate that it be utilized, and it can be revoked at any time, even if it's been signed. We also make sure that families know that having a community DNR does not in any way impact code status while inpatient. So a community DNR is completely separate from a hospital or in the hospital code status. Next slide, please. So we're doing a little more alphabet soup. So a POLST or physician orders for life-sustaining treatment form is a medical order, and it's available to any person with a serious illness. It specifies the type of care that a person would like in an emergency medical situation, and then summarizes it in a medical order that a physician signs. There are different POLST forms for each state. In the states of Missouri and Kansas, we use the TPOP, or Transportable Physician Orders for Patient Preferences form. It applies regardless of whether the patient is in a hospital setting, skilled nursing facility, or living independently in their own community. And that makes it different than the out-of-hospital DNR form. The form is broken down into preferences about CPR or cardiopulmonary resuscitation, different types of treatment plans, such as levels of care in and out of the hospital, medically administered nutrition, and other orders or preferences. Next slide, please.
So I'm going to transition a little bit to our chaplain and social worker access. And I just want to say from the get-go, I'm not representing our chaplains and our social workers by a photo of a dog. Instead, I want to highlight that medical-focused interventions are not the only important piece of palliative care. Addressing a patient's spiritual and psychological needs are essential. Sometimes the best medicine my inpatient palliative team can offer a patient is a visit from Anna, our therapy dog, and a good cuddle. Stress, pain, anxiety scores, they all reduce after a care visit with Anna. A failure to address the spiritual and psychological needs of a patient can really add to the symptom burden and decline their quality of life as a patient faces managing through a serious illness. And it can potentially negatively impact the ultimate outcome of their treatments. Ensuring access to social work and chaplains can help us identify these needs earlier and then better address them. Having a disability is not a form of suffering, and those living without a disability must really take care to not pass on their bias or fears. Quality of life is individual and subjective. Medicine has made huge progress over the past several decades. We can ventilate patients in their homes. We can accommodate physical disabilities better than we have ever been able to. Patients routinely have ICU level cares in their homes, sometimes for their entire lives. Response shift is how we actively recalculate quality of life according to our own personal, individualized physical, psychological, and social well-being. What may have been a quality of life indicator before an illness may change drastically as that illness progresses. And this is a reminder to revisit goals of care, advanced care planning, and priorities on a regular basis. Transitioning priorities can, for some, be very liberating. This is my patient, Tony, and his family, and they gave me permission to share his story today. Tony has a progressive neurologic disease. He was diagnosed shortly after birth. He has relied on his wheelchair since he was a toddler, and he has recently had his 30-year anniversary of his tracheostomy and ventilator transition. He graduated from high school. He's written multiple books, mainly focused on Detroit sports, and he's thoroughly enjoyed his close social circle, social media, and sporting events. These past several years with the pandemic have been especially hard on him and his family, particularly as he has also experienced the ongoing progression of his disease. He has transitioned his care to focusing on staying out of the hospital, focusing on his quality of life, and re-engaging on those activities that were thought previously to be too risky because of COVID, given that his disease is now in its final stages. This has given him and his family really permission to get back out there and enjoy his life. I wanted to share this video. For those of you who are outside of Michigan, this is the Lions Ford Field. And this gentleman right here, this is Lomas Brown, who's a former Lions player. So Tony recently told me after these past 2 years, with the transition of his goals of his medical care, that this has been some of the best years of his life. And I just wanted to use this as an example that quality of life is what it means to the patient, not what it means to anybody else, and to be very cognizant of that. Symptom management challenges in patients with IDD. The healthcare providers really need to partner with the patients and their caregivers. I consider that a patient's long-term caregiver team is really the doctor in their loved one's overall daily life. They know them the best. They can help the healthcare provider really understand when something is new and changing. We really try our very best to focus on the patient's comfort and their dignity. And as we had said previously, healthcare providers must really be highly attuned to changes in behavior, because things like rubbing their hands or their feet might indicate different kinds of pain, like neuropathic pain. Maybe they're trying to manage an itching or tingling sensation by rubbing. Being more watchful for withdrawal, being more watchful for withdrawal of engagement by the patient. Or cue into unusual requests or actions. Ask more questions. Why are you giving away your favorite possession? Why are you saying no to a favorite activity? Missing these subtle signs of changing symptoms or distress can really result, again, in that delay in delivering care that would have optimized their comfort and address their physical and emotional needs. Don't be afraid to engage in the conversations about what it is that is most important to the patient or to their decision makers if the patient is unable to engage. Is the priority to aggressively manage their pain, even if they might be somewhat sedated because of the medications? Or the opposite, maybe they want to be as alert as possible, maybe even at the expense of having less well-controlled symptoms such as pain. Keep the communication open and always be flexible within what the patient's needs are changing throughout their course. So as we're transitioning to hospice, we really want to think about some very specific things. The first is, does the patient's and caregivers' preferences of care align with hospice? Does the patient's prognosis align with hospice? Some other considerations as patients are making the practical decisions are, where do the patients and their caregivers want to be? Do they want to be at home? Would they prefer to be someplace else? Are there sufficient caregiver support for the patient if they decide to remain at home, if that is their wish? If they are changing locations, for example, moving to a nursing home with hospice care, how can we make it more comfortable for them? Can we bring in special photos or belongings to help them adjust? Is their location accessible for their changing needs? Is their location accessible for their caregivers and loved ones? We should make sure to ensure that their caregivers at the facility have regular and easy access to their decision makers. And does the hospice have the skills to care for the patients of their need levels?
So the state of Kansas has a unique statute that makes transitioning to a comfort-focused plan of care a bit more complex for individuals who have a court-appointed guardian. So we're going to discuss what an expansion of guardianship is and what this means for evolving goals of care in the setting of serious illness. Before we dive into that, it's important to define what guardianship is. So guardianship or conservatorship is when the state is attempting to provide a way to help and protect a person when that person is incapable of self-care or of acting in their best interest. So a guardianship or conservatorship should really only be used as a method of last resort and be considered only after all other less restrictive alternatives have been explored. This slide is very busy, but the important pieces are underlined. So in the state of Kansas, a legal guardian cannot consent to withholding or withdrawal of life-prolonging medical care unless the person is in a persistent vegetative state or has a medical condition where any treatment other than symptom relief would either not effectively prolong life or would restore to, or would not restore to an acceptable degree of capability. Next slide, please. So what does all of that mean? So for people in Kansas with a court-appointed guardian who are seriously ill and whose values are most consistent with a comfort-focused plan of care, the medical team can help to pursue an expansion of guardianship order. So what that means, it is a court order that helps to expand the rights of the patient's legal guardian. So two physicians will sign a form that verifies they're in agreement with the patient's medical condition and the appropriateness of an expansion of guardianship order. An attorney then will present this to the judge, and the judge then will decide whether or not to grant the court order. This process is the same whether a patient is in the hospital or outside of the hospital. Next slide, please. So what happens if a judge decides to allow and grant an expansion of guardianship order? So with an expansion of guardianship, the court-appointed guardian is able to change a code status outside of the hospital. So meaning signing a TPOP or an out-of-hospital DNR. They can help to enroll a patient in hospice care if that is in line with their goals and values. And they can also approve withholding or withdrawal of life support and a redirection to a comfort-focused plan of care. Again, if this is in line with what the patient's goals and values are. Any questions on that before we move to the next topic? Okay, next slide, please. So why is pediatric palliative care an important topic to discuss today in this lecture? So pediatric palliative care serves to support children with a serious, life-threatening or life-limiting diagnosis in their families. There are a higher number of children who are growing up with diagnoses that include intellectual and developmental disabilities. This pie chart shows the categories of diagnoses that the Pediatric Palliative Care Team, or PACT team, at Children's Mercy in Kansas City meets. So as you can see, our three biggest proportions of kids who we meet are children with a significant neurologic diagnosis. They make up 31% of our consults, a significant cardiac difference, or an underlying genetic difference, all of which may put a child at higher risk of living with an intellectual or developmental disability. One of our hopes for this webinar today is to get people thinking about involving palliative care earlier on. And I suspect that some of the audience members may be wondering if they or their loved one might have benefited from palliative care support even as early as childhood. Next slide, please. So if you were to advocate for a pediatric palliative care consult, or your medical team suggested involving peds palliative care, what would that look like? So in the first consult, peds palliative care will typically aim to get to know the child and their family. As you can see in this figure, we explore things like hopes and worries, symptom burden, and quality of life, which is really similar to a lot of the concepts that an adult palliative care team will explore. We acknowledge that a good day for a child who may have been born with their life-threatening or life-limiting diagnosis may be different than a typically developing child who received a diagnosis later on. Regardless, we want to learn about a family's values and goals to help prioritize what is most important at that time. And although children and teenagers we meet are often not the legal decision makers, we include them in conversations about their goals and what is important to them. We work with the family to preserve quality of life and protect those good days, as well as serve as a safe space to process and think through some of the scary what-if situations, like if a child, adolescent, or as they transition to their young adult or adult care, they start having fewer and fewer good days, or if they're approaching a new decision-making point, like a tracheostomy or a feeding tube. Next slide, please. These are some additional pediatric-specific resources that can really help support families, caregivers, and providers who work with seriously ill children. I'd like to call out attention to Courageous Parents Network. That's at the bottom half of the slide. So this is a nonprofit national organization that was started by the parent of a child who had infantile Tay-Sachs disease. And it functions as a wonderful resource for parents and caregivers by parents and caregivers, providing support in navigating challenges of caring for a child with a serious illness. They provide videos, written testimonies, and share families' perspectives in their decision-making processes. And they'll explore families who chose to pursue a medical intervention and families who chose not to pursue a medical intervention, such as things like tracheostomies or a gastrostomy tube. I would really encourage all of you to explore these resources. Next slide, please.
So just in summary, we wanted to go through some of the highlights of today's discussions. We're hoping that you all better understand the overlap and the differences between palliative care and hospice care, that you consider early referrals to palliative care with patients who have IDD and are living with severe life-limiting disease. We want to raise awareness of the barriers to medical care overall and palliative care specifically, which include access, transportation, and communication. We hope to improve recognition of when it may be time to consider hospice, particularly when there is alignment in the patient's goals of care and their prognosis.
We would recommend you start advanced care planning conversations early, revisit them often, and consider using resources to help a patient express their values and goals to help guide the plan of care. We have some of those examples down below. And then finally, pediatric palliative care really serves to enhance quality of life, assist with symptom management, and help navigate complex decision-making in children with serious illness.
We wanted to make sure that we gave plenty of space to answer any questions that all of you have. And again, thank you all so much for coming today. We really are so happy to speak with all of you.
Awesome. Thank you both so much. That presentation was incredible and full of a lot of very helpful information. So I think we'll move to the questions in the Q&A chat first. If others have any other questions, please drop them in that Q&A, or you can raise your hand and we can go unmute and you can ask your question directly. So I think we'll start first with a question from Corby Lockwood. What is being done on a national level to educate healthcare providers regarding IDD individuals to avoid stereotypes and to encourage inclusive, equal access to healthcare supports and services?
So I think there's a lot of different levels that have been working actively to do this, both like regionally, some federally, but I think there's a lot of changes right now that make some things unclear as far as advocacy on federal level, though patients with disabilities did recently get a higher level of recognition within the past few years, which really opened up a lot of NIH funding for a lot of different resources. In Michigan, where I'm working at, there is a group called Disability, which helps do that specifically, not only for the University of Michigan, but really the outreach is for the entire state to help educate providers on how to best or better take care of patients who are living with disabilities of all sorts. Taylor, I'm wondering if you have other insight as well.
Yeah. So, I think that groups like KCDD in Kansas can be a really wonderful advocacy organization. I think on a national level, I think about, the National Action Plan to Improve Health Literacy, which was released by the U.S. Department of Health and Human Services. So that was really aimed to help educate healthcare providers about the needs of individuals with intellectual and developmental disabilities. And then there's also on the national level, the National Roadmap for Disability Inclusive Healthcare is another one that comes to mind of just different ways to help ensure that we're hearing the voices of people who are living with disabilities and doing our best to help support them, knowing that there is always room for growth and improvement.
I also think that Allison might have some resources to think about that as well, not just
Absolutely.
us. So,
Um, in Kansas, we have, our Health Equity and Outcomes Coalition, where we're working with healthcare providers to advance some of the IDD specific training for medical students. Because currently during medical school, it's pretty rare for students to have some training and learning around IDD. So advancing some of those practices through like the Down syndrome medical interest group as well. I see Christine Couch. She dropped in a resource, Thinking Ahead, My Life at the End workbook, which uses words, symbols, and pictures collaboratively created by self-advocates in their organizations. Looks like a great tool, Christine. Carla Kearns says, I am curious about review processes for end-of-life care for IDD patients in different states. New York has a process parallel to Kansas expansion of guardianship. Dr. Chargot, do you have anything you wanted to add about Michigan specifically?
so I don't work as much in the pediatric realm. So that specific population, I probably would not be able to speak to as much as I would like to. We don't have the necessity to have an expansion of guardianship if we are transitioning goals within the state of Michigan, but there are a lot of hurdles that have to get there when we do make those transitions for our adult patients. I wish I had better specifics as far as the legal processes. I'm so sorry, guys.
No, that's great. Dr. Jersak, anything you wanted to add?
I just to call attention because we talked a lot about how Kansas does have that expansion of guardianship, which is more unique to the state. And it sounds like New York has kind of a similar process. Missouri, for those who live in Missouri, it does not have that same process, which can be a challenge when we have patients who may live on either side of the state line. I did my training in Ohio, and so I can speak that there's not the same expansion of guardianship process that's needed in the state of Ohio either.
Awesome. Ron Fugate said, is there an IDD-friendly document that helps families and IDD children work through the process of developing advanced directives?
That's what I think that the thinking ahead document, I've seen that before. I think that that is a perfect resource to be able to use and just to have another way for, patients of all abilities to be included in that decision making and thinking about what the future might looks like or what the future might look like and what options there are for pathways forward, whether that's full aggressive medical interventions or starting to fold in more comfort focused plans of care.
I usually use the ones that we've gone through in our presentation here today. So not one specifically for patients with IDD, but hoping to maybe utilize one of the three that might be best for where the patient is at. I love this one that is put in here, and so I'm going to take a look at it as well.
Awesome. The next question, I think, is for Dr. Jersak. How do we go about finding palliative care providers? I think maybe accepting Kansas Medicaid is what
That's a
the
great question. I would say, honestly, one of the best places to start is going through a primary care provider or going through, if there is a subspecialist who a patient or family is most closely tied to, whether it's a neurologist or a cardiologist or an epilepsy specialist, they may be able to help reach out to some of those different providers who are close to you. I think the other thing is just acknowledging that in the state of Kansas and Missouri too, there are many areas of the states with much more limited resources. And so I think that one of the big things that the University of Kansas or the KU health system has done a great job of is allowing for telehealth access or telemedicine visits. I know a lot of the adolescent and young adult patients who I meet through KU will receive referrals from external providers into the KU system, and then we can set up a telehealth visit. So even if you don't live in the Kansas City metro area and you may live 4 to 6 hours away, we are still happy to help see you, especially if there's not an in-person provider who's available closer. And just to name that, again, the palliative care resources and the hospice resources that are within the home will typically be different than palliative care and hospice resources that are available through a hospital system as well.
Awesome. Dr. Chargot, anything to add to that question?
So no, I think very similarly through the University of Michigan, we use a lot of virtual visits and we see patients throughout the state of Michigan. Our communities often have home-based palliative care services, which are wonderful because it's sometimes hard. As wonderful as virtual visits are, they're often challenging to patients to get access to use a video to be able to engage over a video. That there's a certain level of just familiarity that sometimes it's very challenging. Home-based palliative care is usually when it's in the community based through a hospice group that then has a partnered palliative care service. And usually that's a nurse practitioner that'll come in a couple times a month and see a family and the patient and really get to know them. It's a consulting team, just like they would see a doctor. So it's not bringing in other services to the families. It's not bringing in home health aides or nursing on a regular basis, but it's like coming to see a doctor, just the doctor came to see them at their home.
Awesome.
Oh, I'd like to add one other thing about the pediatrics kind of side of things. So the other thing to know is I think that we all acknowledge that adult hospice and palliative care resources are underutilized. And I think the same thing goes for pediatric palliative care and pediatric hospice resources as well. And so if, the pediatric palliative care team at Children's Mercy in Kansas City, we work with many, hospice and home palliative care agencies across the state, knowing that pediatric resources are very, very limited, particularly in more rural areas. And so we will frequently, if there's a patient or family who really wants to focus on time at home, we may partner with the, home hospice or home palliative care agency. And so even if they don't typically accept pediatric patients, we'll serve as either a liaison or a consultant for those rural agencies to be able to help them feel more confident at providing services for patients and families at home. So if there's any, hospice providers or hospice medical directors that are on this call, they're in the state of Kansas or Missouri. If that's ever something that, you're approached with a patient and family who are really hoping to have a more comfort-focused plan of care, I would encourage you to reach out or write down. I think Allison's contact information will be at the end, and then she can put you into contact with our team at Children's, and we would be happy to help. We want to make sure to expand resources for as many children and teenagers as we can in Missouri and Kansas.
Awesome. Thank you. The next question, it looks like we need the contact information for the M Disability Program. So I see Tedra asked that. I have your email, so I'll connect you both so we're not like blasting someone's contact information on the webinar. So I'll connect you both to get that. Then it looks like we have a few folks in the chat who would like just the resources that were shared today. So we'll get you guys links to those resources. This webinar also is recorded and will be up on our website as soon as I can get it up, probably today or tomorrow. So if you want to revisit anything, we will also be sharing that out as well. Anything to add?
I was just going to say here on our end, we'll have all of our resources so hopefully you can reference any of those for anything that you want to delve deeper in. But this is Allison's email.
Awesome. I think that's all the questions in our Q&A. We've got 5 minutes left. Were there any other? Oh, here's one more question. Oh, just a thank you.
Thanks, Audra.
Any other questions? Okay. Well, thank you everyone for joining us today. Please feel free to email me if you have any questions that you didn't have a chance to ask or want to connect offline with our two fantastic speakers today. Thank you both for your time and for sharing your expertise and having this really powerful conversation today. So thank you. Everyone,
Thanks so much for having us.
Thank you.
thank you.